Dr. Vitale and Dr. Brinson, I'd like to propose that SAGES have an award for all the attendees of a 7 a.m. meeting after the sing-off. All right.
I'll pass that on.
So I do have one disclosure. I did receive an honorarium from Medtronic for a speaking engagement. However, they do not manufacture the device I'm going to talk about today. That's the Barks company. The objectives is to determine the complications and effectiveness of endoscopic endolumenal radiofrequency ablation of Barrett's esophagus using the Barks device. Barrett's esophagus is an increasingly recognized sequela of gastroesophageal reflux disease. Barrett's does place patients at higher risk of developing cancer in the esophagus. And because of this, strategies to reduce this risk have either had unacceptably high complication rates, primarily strictures, or have not completely ablated the Barrett's epithelium, primarily in the form of buried epithelial cells underneath the squamous epithelium. So this is the Barks device. It is a radiofrequency generator with a balloon-based catheter. At the end of the catheter, there are coils which transmit the radiofrequency energy to the surface of the Barrett's epithelium. What you don't see here is that prior to choosing the size of the balloon, there is a sizing balloon that goes in first so that the balloon is of appropriate size for the esophagus. And this is what things look like after it's done. This is an area of Barrett's. After 2 rounds of ablations, this is what things look like. It's down to the submucosa. 10 joules at 1 second are delivered, and that ablates the mucosa down to the submucosa, and you essentially have this big ulcer. And after about 3 months, squamous epithelium regenerates. So all patients with Barrett's esophagus without evidence of malignancy were eligible for the procedure, and this includes patients with high-grade dysplasia. Those patients with high-grade dysplasia were also advised that the other option for treatment would be either observation or esophagectomy, and quite frankly, most of the patients who chose ablation were not fit for an esophagectomy. Patients, however, must be fit enough for an endoscopy either with IV sedation or general anesthesia. And patients could have already had a Nissen fundoplication done or could undergo a fundoplication at the time of ablation. So this is the essential steps to the ablation. Upper endoscopy is performed first to measure the length of the Barrett's that you need to ablate. The mucosa is then treated with mucomist to remove the mucus layer off of the esophagus to provide adequate contact of the electrode to the esophageal surface. A measuring balloon is first inserted to size the esophagus, so an appropriate size ablation balloon is then selected. The ablation balloon is placed under endoscopic guidance primarily to ensure that the coils are at least superior to the upper edge of the Barrett's mucosa treated. 2 rounds of ablation are done at each level of 10 joules of energy for 1 second. Patients were then followed up in the outpatient clinic within 2 weeks of the procedure to ensure that there were no adverse events related to the procedure. All these cases are mine, and I do all the follow-up. Post-procedure, patients were placed on twice-a-day proton pump inhibitor therapy to maximize acid suppression. In addition, after the procedure, they are given a oral narcotic, Tylenol number 3 elixir, and Carafate in order to decrease the post-procedure discomfort. A follow-up endoscopy was done at 3 months. If Barrett's is present, reablation is done. If there is no Barrett's present, a follow-up endoscopy is done at 1 year, which is 15 months from the time of the original ablation, and random biopsies from all the prior Barrett's site was done to ensure that no Barrett glands are present. We had a little bit more than what's in the abstract. We're up to 55 patients. However, the conclusions really aren't the same as what you have in your abstract. We had 10 patients with high-grade dysplasia, 13 patients with Nissens, 7 of which already had the Nissens done, 6 Nissens we did. We do have 45 patients who had at least a 3-month follow-up, and 22 patients with now 1 year follow-up. Actually, it's probably not exactly right. It's more like 15 months. So these are the results. The median length of Barrett's treated was 3 centimeters with a range of 1 to 14 centimeters, and the vast majority are in the 1 to 4 centimeter range. We had 45 patients that we did endoscopy at 3 months. However, 3 of these patients had a planned 2-stage procedure because their Barrett's was greater than 6 centimeters, and so we decided to ablate those at 2 separate procedures. So of the 42 patients, we had 26 with complete ablations of an ablation rate of 62%. 16 patients had repeat ablations, and 1 actually had a 3rd ablation done. So at 1 year, 20 out of the 22 patients had complete ablations which were biopsy proven with no evidence of buried glands. We had 2 patients who really had recurrent Barrett's because this was visually seen. It wasn't seen by biopsy, although in fact the biopsy was positive, but they were suspicious for Barrett's epithelium just visually as well. So therefore, out of the 45 patients who did have a follow-up endoscopy, 43 of 45 had complete ablations, and obviously we're still waiting for 20-some of these patients to have their 1-year follow-up. I had 4 patients that did have strictures requiring dilations. 3 were early in the experience when all 3 had Barrett's lengths of greater than 12 centimeters. It is because of this that we broke up the following patients to have ablations done at 2 stages, because I believe that that is inappropriately long. Also, those patients tend to have more chest discomfort after the procedure. 1 patient had a stricture who had a Barrett's length of 6 centimeters. All of them respond to a savory dilation. None has persistent dysphagia. Like I said, did have 7 patients who had prior fundoplications who underwent endoscopic ablation without affecting the function of the fundoplication. Their symptoms, their reflux symptoms were controlled before the operation, and they were controlled after the operation. 6 patients had concomitant laparoscopic Nissens at the time of ablation. We did the ablation first, completed that, and then we went ahead and did the laparoscopic Nissen, and there was no problem whatsoever with any edema or swelling or anything with regard to doing the fundoplication. So in conclusion, endoscopic endolumenal radiofrequency ablation of Barrett's esophagus using the Barrett's device with careful follow-up and reablation if necessary can achieve ablation rates of actually over 95%. Patients with long segments of Barrett should be approached in a 2-stage manner because their risk for stricture is much higher, as well as their risk for postoperative discomfort. Performing a fundoplication at the time of the endoluminal ablation does not increase the difficulty in performing the operation. I should say that I did not put this on my slides, but of those patients who had high-grade dysplasia, in follow-up, none to date have gone on to develop carcinoma. I'd like to thank the Society for the privilege of presenting this work.
Thank you very much. A couple of quick questions while people are coming to the microphones. What were your indications for Nissen fundoplication? Was it symptoms, or did you do pH monitoring, and did you do Nissen fundoplication on those who had severe reflux? And then, secondly, do you feel that the stricture rate of 4 out of your group is high, and is that acceptable, particularly since one of them had a long stricture, which may or may not be resolved with the 2-stage procedure in the longer ones? And then finally, did any of the high-grade dysplasias, you said they did not advance, but did they regress on your studies?
So let me go from the top down. Basically, the indications for Nissen fundoplication were always symptoms. That is to say, they had symptoms of reflux, primarily the typical symptoms of reflux. Despite having Barrett's, I always obtain esophageal manometry and 24-hour pH monitoring prior to any patient receiving a Nissen fundoplication. So that was no different in the Barrett's patients.
And there was no difference in the amount of reflux in the group that you did pH monitoring on who had a Nissen versus those who didn't, or did the Nissen get done on those who had the most significant reflux?
No, the Nissens were done on patients who had symptoms of reflux, had abnormal pH monitoring, and and no evidence of a motility disorder.
Primarily symptom-driven.
Yeah, primarily symptom-driven. If they were well controlled on twice-a-day proton pump inhibitor therapy, I would discuss with them a Nissen, but I would not. Most patients were happy just with the medication, and that's fine. Never pushed the issue. With
high-grade dysplasia, did it change?
Of the 10 patients that had high-grade dysplasia, I have 7 with follow-up, 3 without follow-up, and of those 7, I had to re-ablate 3 of them at 3 months, and at 1 year, I have 5 patients at 1 year, and all of them were free of any Barrett's whatsoever. Your last question about stricturing. This was a big lesson for me, and I would say kind of, if anything, the take home about this is the procedure itself is not technically demanding, but does require attention to detail. And where you get the strictures because the esophagus tends to stick to the electrodes. And because of that, when you advance the catheter down to go to your next segment lower, if you have a segment that's longer than 3 centimeters, you must ensure that the catheter is actually going down and is not re-ablating what you have ablated already. And I think that is the cause of the stricturing, and it is essentially a complication of inexperience.
Okay, we have a question on the floor.
Peter Goretsky from New York. The question I have is about the group with a high-grade dysplasia. You mentioned that most of them were not a good candidate for surgery. How many of them were a good candidate for surgery? And if you believe some of the data that quotes up to 70% invasive carcinoma on the resected specimen, how would you recommend that procedure to a good surgical risk patient?
Yeah, of the 10 patients, I would probably say about 3 or 4 patients could have undergone an esophagectomy. And this is where I spend a lot of time with counseling of these patients. I do tell them that the standard of their treatment for them would be an esophagectomy. And actually, a few patients did go on to decide to have an esophagectomy rather than the Barrett's. I do tell them that the procedure has not had a long follow-up with regard to high-grade dysplasia, and it would still require careful follow-up and could have potentially come to an esophagectomy anyway. So this is how patients then decide to either go on with ablation versus esophagectomy. And I do talk to them about just continued close surveillance with high-grade or with maximal acid suppression with proton pump inhibitor therapy, as that is still considered a standard of care as well. So does that answer your question? All right.
Just a final question. Those with high-grade dysplasia, do you do ultrasound, endoscopic ultrasound on them?
If they had any nodularity or ulceration or any of the signs that places them at even higher risk of harboring a carcinoma, then yes. However, most of these patients, actually all of these patients, had flat Barrett's, so we did not routinely do endoscopic ultrasound on those patients. But any type of nodularity, they would get an ultrasound.
Thank you very much.
All right, thank you.